Now, let us introduce Professor Alessandro to give his lecture. We are proud of him to be today with our journey. And Professor Alessandro is Department of General Surgery and specialized in Spagnoso University of Rome, Italy, Digestive of General and Organ Transplant Surgery Division. We are proud of his work. So welcome, Professor Alessandro, and introduce your lecture. We are with you. Yes.
Yes, can you see my screen?
Yes, yeah, we can.
So thank you very much for this opportunity. I'd like to thank you, Professor Alessandro, and Professor Gams for the opportunity. Of course, I don't have a lot of experience in Metaverse, but I think that 3D reconstruction, especially liver surgery, is maybe the first step for telementoring to understand the anatomy and what else. So I'm assistant professor, as you said, in Department of General Specialist Surgery in Rome, but my training was between the United States and France, in particular Paris. So first of all, 3D liver reconstruction represents an important advancement, especially for preoperative planning, surgical simulation, intraoperative navigation. It combines advanced imaging like CT, MRI, and of course ultrasound sometimes to modeling with modeling technique in order to visualize the complex anatomy. Of course, we used in HPB surgery for volumetry assessment. The first things that we think is about liver segment and calculation, of course, for future liver remnant. It's important also for tumor localization, vascular structure, in order to understand also the risk for R1, so the risk for margin, and also to predict any ischemic areas after major or minor resection, in order to understand also the remaining vascular supply. But how it works, everybody talk about 3D reconstruction, but there is something that maybe we need to know. First of all, we need some good quality imaging like CT or MRI. I will speak about ultrasound reconstruction, but it's something very advanced that we don't have a lot of experience now, especially in Europe. So we need a good quality CT scan or MRI, and the data format that we need is a DICOM, of course, with high resolution sectional image, and the technologies that sometimes are used is a 3D reconstruction algorithm based on deep learning. We can see what I named like ETK or VTK with the deep learning approach in order to reconstruct the 3D. And then we use the output format like STL, that it's very important not only for imaging but also for printing a 3D liver that used sometimes the volume rendering that we need. It's merging cubes or ray casting that are semi-automatic algorithms. And then we have the 3D reconstruction, of course. As I said, the first step that we used for the first things that we need to use is for volumetry and outcome, especially for major resection or living donor liver transplantation, to ensure, of course, a good future liver remnant that is fundamental for a good outcome. We have two important reconstruction: the manual delineation, that is conventional, serves a standard approach. It's low cost, of course. Any cost, we have the automatic segmentation algorithm that, as I show in this study, published in 2012, we have some advantages, of course, for automatic volumetry, but we have pretty much higher error for volumetry. Of course, so for the manual delineation, it's time demanding. We have a lot of formulae that now we don't use with the new technologies in radiologies. We don't use any mathematical or logarithmic a formula in order to understand the volume. So we used in our area, of course, automatic volumetry. But 3D reconstruction is not something that it's very simple. We need to understand the software that you want to use. We need to understand the anatomy, and also for young surgery, it's a very helpful tool. HPB surgeons face a significant mental workload to reconstruct the tumor position and the anatomy of the liver, of course. And they need an HPB surgeon need experience also for CT interpretation. In particular, in minimal zero surgery, the challenges is increased for altered visualization and the programming, also the trigger, if you want. But 3D reconstruction helps to render this approach less demanding in spatial orientation. But in these studies, of course, we need to understand that there is a learning curve. So the first cases maybe are more time demanding than the last patients that you want to reconstruct. 3D reconstruction is very important for parenchymal sparing liver surgery, in particular in colorectal liver metastasis. This is some imaging that I did with the help with Professor Gaillet when I was in Paris. I show here a segment 4. Segment 4 is well known to be divided in two parts, apical and basal. But if you want to really do a sub-segment, you need to understand the supply, the vascular supply, and sometimes we need to understand the pedicle that supply this sub-segment. And in this photo, show that there is more than one segment for example. Of course, it's very important and useful for young surgeon perspective, not only for all the liver, but also for the vascular anatomy. For the vascular anatomy or aberrant vascular anatomy. In this study that is published, it's just published in 2024 in Journal of Surgical Education, they also compare the performance in terms of number of lesions, site of lesion, presence of vascular variation or type of anomalies. CT, they evaluate the CT and 3D reconstruction. And of course, with 3D reconstruction, we have a better performance in young surgeons, but also in medical students. So in other words, 3D reconstruction is suggested to use, especially in the first years of the residency, especially in HPB surgery. This is another study that I'd like to introduce you. It's very important from a Japan group. They did something more. In other way, they did a training using a simple training using a dry box with an assessment with the mentors. And after that, they did also a pre-operative 3D simulation. And I will show how much is important not only the 3D reconstruction, but also the dynamic virtual hepatectomy that really can give a way in more to understand this kind of surgery. And the results are amazing because for a laparoscopic left hepatectomy, young surgeon, after this assessment and training and assessment, they have better results than the senior surgery. Also in pretty much the same operative time, and I can assure that left hepatectomy is not an immediate liver surgery and no significant difference in morbidity or in conversion rate. So this is very important to underline also the virtual hepatectomy role. This is a case that I like to show we did a 3D reconstruction in collaboration with SurgiPrint. Unfortunately, when I came back in Rome, I didn't have any software available for 3D reconstruction, but this is a kind of telementoring with a startup, if you want, with SurgiPrint from Belgium that assisted me with 3D reconstruction. This is a case of colorectal liver metastasis, bilobar metastasis. And just to show you how important is not only the 3D reconstruction, but also the ultrasound intraoperative guide in order to do the parenchymal sparing in the liver. Unfortunately, I didn't have a good screen, but I took with myself the personal computer in order to have a real-time 3D reconstruction. Um, Also, what I want to show you some software that are amazing in this area. It's the virtual and dynamic hepatectomy. I think that not only the 3D reconstruction is important, but also the 3D virtual hepatectomy that give. It's not very simple to do this virtually, but it's a first step in my opinion for a metaverse telementoring, because you can understand with your mentor which is the vascular supply, which is the vascular line to follow, which segment, and I think it's very important. We did the same in this is on the right, another case that we did in at EMM in Paris with Professor Gaillet. So in the blue area in the liver, it's the vascular. I'm sorry, is the area supplied by the distal part of the middle hepatic vein that was touched by the tumor in red, and we need to modify the line of the hepatectomy thanks to the 3D and the virtual hepatectomy. Below here, it's one of the most important study at the moment, because I remember you that we don't have any clinical trial that ensure 3D versus CT scan for liver hepatectomy. But this is a retrospective study, a very solid retrospective study published in Annals of Surgery in 2018. They compare virtual hepatectomy patient that underwent to hepatectomy, major hepatectomy, of course, and with the preoperative virtual hepatectomy and non-virtual hepatectomy for colorectal liver metastasis and hepatocellular carcinoma. And as I show you, the recurrence-free survival for virtual hepatectomy was better significantly in patients that underwent in virtual hepatectomy. I didn't spend a lot of time to show you all the studies, but I recommend to see the study because it's one of the most important and the solid study that support the 3D reconstruction. It's not only a qualitative study, but also a quantitative study. The next step, of course, is augmented reality. So before the conclusion, augmented reality, I think is the dream for each hepatobiliary surgeon, because ensure the intrahepatic anatomy visualization. It's a kind of digital imaging that we can follow during the surgery. Of course, we have a lot of study, a lot of tentative. Of course, the group from IRCAD published with the virtual patients a lot of study and application about patients series for this kind of surgery. But what I understand in all these applications, there is no real deformation and no calibration for 3D reconstruction. In other words, after the first cutting of the liver, we don't have the real imaging. So we need a 3D reconstruction and augmented reality that change during the surgery. This is one of the most important limitation that we need to beat to improve this kind of application. And when I was a resident of Paul Bruce, we had a little experience. Some mark to follow the liver. We concentrate ourselves in our technology, that is a camera, RGBD, red, green, blue depth camera, that was very important to understand to follow the surgery. And this is very important also for the surgery that is telementored is and in which step is it. So this is just to give you an idea how much complicated is augmented reality. We had a little experience, and in particular, we used the 3D reconstruction after a segmentation with a calibration, in particular with a software that is called SOFA. But we did not publish any kind of result because that it was a failed of I'm sorry of of the result, because as you see in this photo, we you have of course a good calibration of the augmented reality during the simulation. This is a fake liver, but if you see the photos, when you push the lever, you can imagine if you want to do a major resection of left lateral resection, of course you have to move the lever. Of course, all the red point did not follow the lever. So just to give an idea how much important is augmented reality, but augmented reality should follow the lever and the resection. So the first step, of course, is augmented reality for the metaverse. It's the 3D reconstruction, but we have a lot of technology, and you said before, I don't want to waste time because you already, as expert, show all the technology, the needs, and the answer that the metaverse can give us. But just this to give an idea that all this technology maybe stand around the 3D reconstruction and the augmented reality. Again, metaverse telemonitoring, we already have, especially in HPB surgery, some cases that are already published. In particular, a group from China and a group from Spain that use an intraoperative support with lens that can give a remote mentoring during the surgery. They did an evaluation during 1 year long for all the HPB surgery. So, before the conclusion, we need to understand that the 3D reconstruction is very important, but there is some limits. In particular, it's time consuming. High cost, especially we have in Europe software that are amazing but are a little bit expensive. And of course, we need to do the data integration for artificial intelligence integration for data, also for prognosis, to understand the prognosis of the patients. The future, concerning the future perspective, of course, we need to automate the 3D reconstruction and to integrate in a real way in augmented reality. We need also to do that to integrate the ultrasound, not only CT scan or MRI, and we need to integrate all this in robot surgery, because it should be the future, especially for the telementoring. In conclusion, so 3D reconstruction is essential, improves the learning curve of the young surgeon, and it's can ease but the operative point of view, but also for the imaging interpretation for the young surgeon. It's the most important function that we need to understand and to know is the virtual hepatectomy function. And in my opinion, 3D reconstruction is the first step for augmented reality, but also for metaverse. So thank you for your attention.
Thank you, Alessandro. That was a very beautiful talk. I see you work with some of my old colleagues and friends. So you're doing wonderful work there. Mohamed, I think you're trying to speak and we don't hear you.
So, of course, thank you, Professor Alessandro, about the presentation, and of course, all the documents and all the evidence data with us now. And of course, it will be a revolution of what we are doing. And even the Da Vinci team, intuitive engineers, they called us, we work with them to develop the new generation Da Vinci X5 now, in which that you will see that it has a virtual reality and metaverse in the surgeon council. If you see that if you are doing a liver surgery and you need a virtual reality, or augmented reality, it is supplied with this AI technology. We feel proud to introduce this discovery with them after they saw our work, which extended for the previous 2 years. So, of course, now you saw everything, Professor Andrew. Professor Michel is with us now 2 years, and we feel proud to open the Artificial Intelligence and Metaverse Research Center in the European Union with Magna Graecia University. And of course, all of you are invited with us in this research center to develop this work more and to expand it more and to make more workshops in order to implement it work. Before about 3 days, I was having a workshop in Dubai. Scientists from South Korea, US, from Japan, they came, and from Tanzania. Maybe you saw it on my media. They were amazed about what they saw. So we are living a real revolution, and of course, to the space together.
Alessandro, you think that is useful only for planning surgery?
Michele, I think you have to turn off your metaverse connection.
Yes, please, Professor Michel. I wanted to be out of the metaverse in order to be on the Zoom, or out of the Zoom to be on the metaverse. Choose one.
I am the Zoom, but
you have echo in your voice. Yeah. Why?
Okay.
Yes,
Yeah.
now better.
Okay. So, Alessandro, you think that is useful only for planning surgery or also for follow-up check after the therapy or surgery treatment? The audio, Vale.
Yes, of course, it's well studied for preoperative planning, but there is some studies also to understand post-hepatectomy. We know that after hepatectomy, we have sometimes an intrahepatic portal hypertension. And I think that morphology of the liver can give us some answer to follow up the patient that can develop post-operative portal hypertension. So I think that this is very important, and I think that it's useful for radiotherapy follow-up, for thermal ablation, but also to new definition of R1 margin for for pathologists, because I think they did know how to interpret the CT scan, but with 3D reconstruction, we can really redesign the TNM classification for some tumors with 3D reconstruction.
Yeah, I agree. Thank you very much.
Thank you.